Hello, my dear students. This is Dr. Rohith Daniel, your orthopedics faculty from DocTutorials. Today, we'll quickly discuss the INI CET November 2024 orthopedic recall questions. And if you have any doubts or clarification, you are welcome to type in your comments in the chat box. Yeah. So we'll quickly discuss these questions one by one. Before that, a general discussion about the ortho questions in the paper. It was a moderate paper, I would say. Usually the orthopedics questions in INI CET papers used to be quite difficult, but this time it was not the case. Most of the questions were of more of a neat PG kind of questions. And I think all of the questions came from previous year topics. Therefore, I think it was quite easily answerable. Now, before discussing our questions, I would just like to tell you some disclosures. First and foremost, all the questions are assimilated from the recalls of students. So obviously, different students will have different recalls of the same question. So the questions format and structure might differ. The options might differ because most students would remember only the correct answer or the correct option. The other options could be different. And images, obviously, we have no way to get the exact similar X-rays and images. So obviously, we put an image or X-ray which is best suited or most similar to what students have told us. All right. So with that in mind, let's start with the first question. A straightforward, simple question, I would say. Which of the following is a feature of posterior interosseous nerve injury? Is it a wrist drop, weakness of extension of wrist, weakness of extension of fingers, or weakness of forearm supination? What is the answer here? Very easy, isn't it? You have the posterior interosseous nerve. What is posterior interosseous nerve? It is a branch of your radial nerve, isn't it? It is a branch of radial nerve, and its primary function is to supply the extensors of fingers. What is the function of the radial nerve? It supplies the extensors of the wrist. The posterior interosseous nerve specifically supplies the extensors of the fingers. So when the posterior interosseous nerve is paralyzed, the patients will have a weakness or inability to dorsiflex the fingers. So that is the correct answer here. Weakness of extension of fingers, and this condition is what we call as finger drop, isn't it? Finger drop. Now, what are the conditions that can cause posterior interosseous nerve injury? See, the important thing to remember here is that the posterior interosseous nerve actually passes very close to the head and neck of your radius. It passes very close to the head and neck of radius. So any injury here near or around the head and neck of radius can cause posterior interosseous nerve injury. So this could be a radial neck fracture, radial head dislocation, or Monteggia fracture, where you have a proximal ulnar fracture with dislocation of the radial head. So any of these injuries can actually cause posterior interosseous nerve injury. All right. The next question, what is the full form of FRAX score? I have told my students that FRAX score has become important because even in the last FMG exam, we had a question on FRAX score. What is FRAX score? Is it fracture repair assessment tool, fracture risk assessment tool, fracture rehab and assessment tool, or fracture remodeling assessment tool? What is the correct answer? Yes, it is your fracture risk assessment tool, isn't it? So where do you use it? See, it is used in osteoporosis. Osteoporosis. Okay. So it is actually a questionnaire and clinical assessment based tool which we use in osteoporotic patients. And here we use it to calculate 10-year probability of fracture if the patient is untreated. The patient has osteoporosis and we do not treat it for a period of 10 years. And what would be the chance of a fracture? That is your FRAX score, a fracture risk assessment tool. All right. Next question. A 20-year-old man presents with sacroiliitis and uveitis. Which of the following markers would be positive in the case? What is the answer? Is it HLA B27, rheumatoid factor, ANA, or ASO? We know that sacroiliitis and uveitis combination occurs in which disease, especially in a 20-year-old man. What is the condition? Yes, it is in ankylosing spondylitis, isn't it? Ankylosing spondylitis. And in ankylosing spondylitis, the blood marker that becomes positive is what? HLA-B27. Rheumatoid factor is positive in rheumatoid arthritis. ANA and all are positive in SLE, isn't it? HLA-B27 is where ankylosing spondylitis, HLA-B27 becomes positive. That is the answer here. Next question. A 40-year-old male presented to the emergency department with history of fall. X-ray shows intracapsular neck of femur fracture. What is the ideal treatment? Is it hemiarthroplasty, total hip replacement, open reduction and internal fixation, or close reduction and internal fixation? What do you think the answer here is? The key is the age. It is a 40-year-old male. So you cannot randomly treat the patient like that. So you have to follow a particular protocol that we use to treat fracture neck of femur. Here we take into account two things. We take into account the age of the patient and the presence or absence of osteoarthritis of hip. All right. So if the patient's age is more than 65 and there is no osteoarthritis, we do a hemiarthroplasty. If the patient's age is less than 65 and there is no osteoarthritis, we do a fixation of fracture. And if there is osteoarthritis, irrespective of the age of the patient could be above or below 65 years, but if there is osteoarthritis, you cannot do anything else. You have to do a total hip replacement. Now, in this question, the patient is 40 years, so it is less than 65 and there is no mention of osteoarthritis. A young patient unlikely to have osteoarthritis. So we have to fix the fracture. But the question is how to fix. The treatment is closed reduction and internal fixation. That is the answer here. And we use screws for fixation, cancellous screws for fixation. Okay. So close reduction and internal fixation is the answer here. We do not do open reduction. Why? There is a high risk of AVN because of high risk of avascular necrosis of femoral head. We do not do open reduction. Okay. So if you do an open reduction, you are further compromising the blood supply to the femoral head and you will end up in avascular necrosis. So we do not want that. We close reduce the fracture and fix the fracture. All right. That is the answer there. Next question. Which of the following is not a feature of psoriatic arthropathy? Is it diarrhea, enthesitis, dactylitis, or nail pitting? What is psoriatic arthropathy? It is a polyarthritis or polyarthralgia, which is associated with the skin condition of psoriasis, isn't it? And here you can find enthesitis, dactylitis, and nail pitting. All these three findings would be there. Diarrhea would not be there. Diarrhea is actually seen in which condition? It is seen in enteropathic arthritis. Enteropathic arthritis, which is associated with which condition? Crohn's disease as well as ulcerative colitis. In these two conditions, you can get associated enteropathic arthritis, which can lead to diarrhea. But in psoriatic arthropathy, classically, you have enthesitis, dactylitis, and nail pitting. Psoriatic arthropathy and ankylosing spondylitis are the two conditions which are very often associated with enthesitis. What is enthesitis? What is enthesis? So if you have a bone like this and a tendon or ligament coming and attaching to it like this, the point of contact, a point of insertion of the tendon or ligament on bone is called enthesis. This point is the enthesis. Okay. So you could get enthesitis, inflammation of the enthesis in psoriatic arthropathy. Dactylitis is what? Dactylitis is arthritis of the joints of fingers. Okay. So joints of fingers can be affected, and usually the distal interphalangeal joint is classically affected in psoriatic arthropathy. Generally in rheumatoid arthritis and all, DIP is classically spared. You don't get involvement of DIP in rheumatoid arthritis. Psoriatic arthritis, the most common involvement is the DIP. So remember that. And nail pitting, we all know, is a classical feature of psoriasis. Okay. Next question. The sixth question is probably the most confusing question because different students had different version of it. A 65-year-old lady had sustained a trivial fall resulting in multiple fractures. X-rays are given below. What could be the cause of fractures? And from what my students told me, there were three X-rays that were given. One was a fracture femur with a lytic lesion. Like this, you had a lytic lesion with a fracture. Then you had a fracture of the tibia with a lytic lesion. And there was also an X-ray of the pelvis showing multiple lytic lesions like this. And few students said that in one side, the acetabulum also was completely destroyed. So basically, there are multiple lytic lesions in the body. And because of the trivial fall, there has been fractures. And this is what we call as pathological fracture. Pathological fractures occurring because of the weakening of bone because of an underlying disease of the bone. That is your pathological fracture. And there are lots of causes for pathological fractures. So the options given were disseminated TB, brown tumor, eosinophilic granuloma, and metastasis. Let's look at the options one by one. Can disseminated TB cause multiple fractures like this? Disseminated TB usually means multiple systems are involved. Your GIT, your liver, the spleen, everywhere there would be infection with tuberculosis. Skeletal system can also be involved, but multiple fractures are rare. Okay, multiple fractures are rare. It can occur, but it is rare. What is brown tumor? Where do you see brown tumor? Brown tumors are seen in hyperparathyroidism, isn't it? Hyperparathyroidism. Again, there could be multiple fractures like this, but again, hyperparathyroidism is quite rare. Then what about eosinophilic granuloma? It is a condition usually seen in children. So the age is 65 years, so unlikely to be eosinophilic granuloma. Finally, we have metastasis, which is the most common cause of multiple lytic lesions like this. Okay, multiple lytic lesions. Why? Because it is the most common malignancy of bone. It is not osteosarcoma or multiple myeloma or anything. The metastatic disease, metastatic bone disease is the most common malignant lesion affecting bone. All the others incidence is much lesser. Okay. So the best answer to this question is the most commonest one, which is metastasis, which we often see like this. A patient might have CA breast or CA lungs, which was treated 5-6 years ago. The patient would become better, and one fine morning, the patient would fall and come to you with multiple fractures. You take x-rays and you will see that there are multiple lytic areas. Probably this was an undiagnosed or unnoticed metastasis. That is the correct answer. Okay. All right then. So these were the 6 questions from what I could gather. So if you have any additional points to add, please do so in your comment boxes. And if you feel that some of the options or some of the questions were a little bit different, then feel free to write your opinion in the comment box as well. So anyway, I hope that you had a wonderful exam and all the best for your upcoming results. All right. Thank you.
Pwede, panig ang glass.